Hello and welcome. Well, as you can see from the title on this slide, this talk, as opposed to a lot of the material that we have covered previously, is unique in that it is specifically focused on a specific disease state and a specific pathophysiology, in this case, aortic stenosis. While in the past we've covered more general topics, general applications, whether it be qualitative or quantitative applications in echo, which can be applied throughout a wide cross-section of disease states. This is a specific evaluation for aortic stenosis. So with this, just like other disease-specific material that we'll cover, um, even though it's not specifically within the intensivist scope to be able to diagnose or to need to diagnose aortic stenosis in their patients, this is an important topic to be able to understand for two reasons. One, because knowing whether or not a patient has AS pathophysiology can have a very direct bearing on what you do in that patient's care as an intensivist. And number two, the basic evaluation and monitoring of aortic stenosis really takes the knowledge and skills that you have already acquired with the previous material, just applying it in a different way. So it's very much within your wheelhouse to be able to identify this pathophysiology. And then once you identify it, then get the formal echo to confirm it and to get sort of more formal measurements and evaluations. But again, this is a way to use the skill set that you already have and apply it to the identification of a pathophysiology that will have very real implications on how you manage a patient in the ICU or in the critical care setting, minute to minute, hour to hour. All right, so with that, let's start. The evaluation for aortic stenosis, just like a lot of echocardiography and a lot of cardiac physiology and respiratory physiology and critical care as a whole, relies on the understanding and the application of Ohm's law. Now, as you guys have already learned many times over, Ohm's law describes the fluid dynamics relationship between flow, pressure gradient, and resistance. So you have a compressible fluid moving through a system. This law describes how these three variables relate to each other. Flow is directly proportional to a pressure gradient across the system through which the fluid is moving, and inversely proportional to the resistance that that fluid is facing. Or if you solve for pressure gradient, the pressure gradient is directly proportional both to the flow and the resistance. Okay, simple. When we're talking about aortic valve evaluation and aortic stenosis evaluation or aortic valve dynamics, the flow in this case refers to stroke volume. The pressure gradient refers to the pressure gradient across the aortic valve. And the resistance, similarly, describes the resistance across the aortic valve. So when we evaluate for aortic stenosis and try to get an idea of the severity of aortic stenosis, there's really two things that we can use to make that determination. One is the pressure gradient across the valve. So the higher the pressure gradient that you're experiencing across the valve, the tighter that valve is, the more stenotic that valve is going to be. And you can also look at the aortic valve area. So obviously, the smaller the aortic valve area, the worse the aortic stenosis is going to be. And you guys know this from medical school and residency, that these two methods for describing and categorizing AS severity are sort of described here. So like I said before, as the aortic stenosis severity goes from mild to severe to critical, one way of looking at it is by measuring the pressure gradient. So the higher that pressure gradient is across the aortic valve, the worse the stenosis is going to be. So, all the way from less than 25 all the way up to greater than 70, the higher the mean gradient is, the worse the aortic stenosis is. The other way you can look at it is by looking at the aortic valve area itself. So obviously, the larger the aortic valve area, the less severe the aortic stenosis is, and the more tight the valve area is, the worse the aortic stenosis severity would be. So let's talk about that first sort of parameter, mean pressure gradient. So as we looked at when we looked at that Ohm's law equation, the pressure gradient is dependent both on the aortic valve resistance or in other words, the severity of the aortic stenosis, as well as the stroke volume that's being pushed across the aortic valve. So, in other words, as the aortic valve resistance increases, or in other words, as the aortic stenosis gets worse, the pressure gradient increases. And this concept is why we use pressure gradient to help categorize how severe the AS is. But as stroke volume decreases, the pressure gradient is going to decrease as well. And one thing that we know about the case history of aortic stenosis is that for some time, LV function will be preserved, but over time, as the stenosis gets worse and gets more long-standing, eventually you will develop LV systolic dysfunction. And when you develop LV systolic dysfunction, what's going to happen is the stroke volume is going to start decreasing. So what will happen over time when you're looking at the evolution of aortic stenosis is that pressure gradient will continue to increase and increase and increase as the aortic valve itself gets tighter. But eventually you'll reach a point where the LV fails, then the pressure gradient will start to decrease. Or in other words, it will start to less reliably mirror how severe the aortic stenosis severity is. So that's the limitation of pressure gradient, is that over time, it does not take into account changes in a patient's LV function. So as the LV function gets worse, the pressure gradient will become a less reliable method of gauging aortic valve stenosis severity. The advantage of pressure gradient is that it's pretty easy to measure. All you do is take Doppler and put it across the aortic valve. But like I said, over time, its representation of aortic valve severity will start to break down a little bit as the LV starts to fail. So that leaves us with the second measurement, the second determiner of aortic valve stenosis severity, which is the aortic valve area itself. And there's two ways to measure the aortic valve area. There is the direct method, where you use a transesophageal echo, and you get a very close, very high resolution picture of the aortic valve itself in cross section. And you actually do a direct tracing measurement of the open aortic valve to determine what the area is there that you're seeing. And that method is called planimetry, where you actually look at the open aortic valve, trace it, and the computer tells you the area within what you traced. This by far is the most accurate and reproducible method that's there to measure aortic valve area. But the downside, of course, is you have to do it via TE. 9.7 times out of 10, you don't get as high resolution of a picture of the aortic valve using TTE. So to really be able to do planimetry in an accurate way, you have to get a TE. So that limits how many times you can use it. Typically, this will be done to make decisions on surgery, and things like that. But it's something that you can't really do very frequently. Okay, but there is a method you can use with TTE, and it's more of an indirect measurement, and that applies what's called the continuity principle. And we'll talk about that. So here's what planimetry looks like. So these are transesophageal images of the aortic valve in cross section using transesophageal echo. And you can see that this is an open aortic valve. What you do is you basically will get a video, you freeze it when it's the most wide open, and then you basically take a line and you trace that opening. And the computer will give you the area within what you traced. Here's a normal aortic valve, and here's a stenotic aortic valve. Believe it or not, this valve is open. So this is a stenotic aortic valve. And if you measure or if you draw that opening or trace that opening, it will give you the area within there. And you can see over here that area is less than that's 0.81 in this measurement. Okay, so normal stenotic aortic valve. But again, to get this degree of resolution, 9.7 times out of 10, you have to do a TE. Okay. So we talked about the idea of using what's called the flow continuity principle to apply transthoracic echo to get an estimation or measurement of aortic valve area. And the way we do this is by understanding flow continuity. So what flow continuity says, what it tells us is that if you have a closed system, like the heart, the flow at any point throughout that closed system has to be the same, has to be constant. Okay, so if we're talking about cardiac physiology, flow is stroke volume. So what that tells us is the stroke volume, because the heart is a closed system, the stroke volume has to be constant no matter where you're looking in the heart. It has to be the same. So for example, if you take 2 points within the heart, like the LVOT and the aortic valve, the stroke volume through the LVOT has to be the same as the stroke volume through the aortic valve as long as the system is closed. Okay. In other words, stroke volume at the LVOT equals stroke volume at the aortic valve. And what you remember from the quantitative LV assessment that we talked about previously, one way you can measure stroke volume is by multiplying the cross-sectional area of where you're measuring by the velocity time integral of where you are measuring. So in other words, cross-sectional area of the LVOT multiplied by the LVOT VTI has to be equal to the aortic valve area times the aortic valve VTI. And if you solve for aortic valve area, cross-sectional area of the LVOT, which is pi r squared of the LVOT, multiplied by the LVOT VTI, divided by the aortic valve VTI, will get you your aortic valve area. So this is an application of the flow continuity principle to essentially solve for the aortic valve area using velocities and cross-sectional area measurements. Okay. The question is, how do you measure? So we know how to measure this. We know how to measure this. We've done this already when we talked about quantitative LV assessment. The question becomes, how do you measure the VTI at the aortic valve? Remember, when we talked about basic Doppler, the basics of Doppler, we talked about two sort of types of quantitative Doppler that we utilize. There's what's called pulsed wave Doppler, which is a mode of Doppler that we use to measure the velocity at a specific point. So in the case of quantitative LV assessment, we use pulsed wave Doppler at the LVOT to get the LVOT VTI. On the other hand, continuous wave Doppler, like you remember from the RV talk, gives you the maximum velocity or maximum VTI all along that entire Doppler line. So whereas pulse wave Doppler gives you the velocity at that little bracket that you see with the pulse wave Doppler, continuous wave Doppler gives you all the velocities along that whole line, and it tells you what the maximum velocity along that line is going to be. And again, back to Ohm's law, we know that the velocity across a system is going to be highest at its narrowest point. So if we're going from, in this case, our apical 5 chamber view, we're going from LV through LVOT through the aortic valve, what's going to be the narrowest point? That's right, the narrowest point is going to be through the aortic valve. So if you take in your apical 5 or apical 3 chamber view, you take continuous wave Doppler and you put it through the LVOT and through the aortic valve, the VTI that it gives you is going to be the VTI through the aortic valve. All right, so to bring it home, by continuity, the way to estimate aortic valve area is to take the cross-sectional area of the LVOT measured in the parasternal long axis view, the LVOT VTI done with pulsed wave Doppler with the bracket at the LVOT, just like we do when we're measuring stroke volume. And then you divide it by the aortic valve VTI, which is obtained by taking continuous wave Doppler in your apical 5 or 3 chamber view through the aortic valve, all the way through the aortic valve. Okay, and then you just solve for aortic valve area. So this is how we sort of manipulate the numbers to solve for aortic valve area. Now, as you can see, this is a very sound, conceptually a very sound way of measuring aortic valve area. But you can probably see, just by looking at this equation, where there are going to be places for introduction of error. Okay, the first place is going to be right here, the cross-sectional area of the LVOT, specifically the LVOT diameter / radius measurement. Okay, you have to make sure that this measurement is as accurate as possible, because again, any error is going to be squared, and any error here is going to significantly cause deviations in the number that you get for the aortic valve area. Okay, so first you want to make sure that when you're measuring this, you are as on axis as possible and getting as crisp and as perpendicular of a measurement as you can through the LVOT. And if you want to, see how to do that again, please go back to that quantitative LV talk, and it goes through how to accurately measure that. So this is one source of error, probably the biggest source of error. The other source of error is going to be here. It's very important that when you're doing your LVOT VTI measurements and your aortic valve VTI measurements, that you're using the same view, and that most importantly, your theta angle is not changing between these two measurements. Okay, you want to make sure that you're measuring pulsed wave and continuous wave Doppler in the same view with the same angle. And the way you do that essentially is to keep the probe on, get your pulsed wave Doppler measurement first, save it, and then unfreeze and get your continuous wave Doppler measurement. Just to make sure that the views are giving you theta angles that are the same. Okay, so there you go. Quick and dirty on how to identify aortic stenosis pathophysiology and how to measure and estimate the severity. So like I said, even though this is well within your scope of skill and knowledge, this is still something that once you identify the pathophysiology, get that formal echo to get confirmation and to get more formal numbers. All right. Any questions? You know how to reach me, and I look forward to scanning with you.